All right, everybody, good morning. Can you all see me? You don't have to
Yes.
see me though. Can you hear me? That's what's important.
Yes.
Yes.
All right, you can see my screen too, correct?
Yes.
Yes. Yes.
All right. So we're gonna go over chapters in the new book. It's gonna be 47, 48, and 49. So in the new book, it's 47, 48, and 49. Pituitary and adrenal disorders and thyroid and parathyroid. Okay, pituitary and adrenal disorders, thyroid and parathyroid. So next week, Friday, will be what date? The 20th, right? So the exams is going to be over pituitary, adrenal, thyroid, parathyroid. Okay. So whatever we're teaching today, we'll be testing over next week, Friday. All right.
Alrighty.
Okay. All right. So what we talking about adrenal disorders, pituitary and adrenal disorders, we're trying to look at hormones. Okay. What we're trying to deal with here is the hormones, what they do in our system. I'm having some problems with my projector here. Okay, it's working now. So, these chapters are basically, it's up to you to try to draw comparisons between the disorders, and that's it. You draw a straight line, okay, a horizontal line, and a vertical line. You put one here and the other on the other side. Just oppose the two, and it should be fine. Put all the disorders here, the signs and symptoms, and put the disorders on the other side. So when I'm talking about Cushing's disease, the opposite is Addison's. So if you know everything that goes on in Cushing's, is the opposite for Addison's. Okay, it's very very easy. If you understand it, you don't have a problem. So first, let's start with the endocrine system, the introduction to the endocrine system. So what you need to know here is the fact that it's got to do with hormones. Okay.
You got what? Put it on VGA. Where it says it's on HDMI.
All right. So let's continue here. So what we want to know, or what we want to talk about here, is hormones. What are hormones and what do they do in our body? That's what you need to ask yourself. So hormones are released in response to body's needs. So if I'm thirsty, there is a hormone that's going to be released that's going to make me go drink water. When I'm hot, there are hormones that are going to be released that's going to make me what? Cool down or sweat, and then your body cools down and the temperature goes down. Okay. So we have what we call the endocrine system, which tries to maintain what we call homeostasis. What is homeostasis? It's the same as equilibrium. Okay. It is what? The maintenance of physiological stability despite constant changes in the environment. That's called homeostasis. That's how your body works so that you can what? Live a good life, right? When you're hungry, there's a hormone that is released that tells you you're hungry, you gotta eat. When you're hot, when you're what? Emotional. Why do you cry? Stuff like that. Okay, why do you get angry? Okay, when you're ready to fight, what are the hormones that you release? All of that, Okay, they control your body so you can be in what? In an equal balance so you can survive. So we have what we call feedback mechanisms that help in these situations. Okay, we either have the positive feedback mechanism or the negative feedback mechanism. Okay, so when we talk about positive feedback mechanism, we're trying to look at what? More release of the hormone will cause more effect to happen. A negative feedback mechanism is when less of the hormone will be released for the effect to take place. So, an example of a positive feedback mechanism is childbirth. In childbirth, what is going on? What is the hormone that is released for the child, for the mother to have a contraction of the uterus? What is it called?
Oxytocin.
Oxytocin, exactly. So with oxytocin, there is more release of the hormone, and the contraction goes on until what? The child is born. So that is what? A positive feedback mechanism. Okay? So with a negative feedback mechanism, less of the hormone will be released for the effect to take place. And an example is insulin. Okay, secretion of insulin, right? When insulin is released, what goes on? Converts glucose into, and then when you're hungry, what happens? Less insulin will be released, right? Okay, so that's negative and positive feedback mechanism. But I'm not going to question you on that on any. Okay, now let's look at the what's very important in our body is what we call the adrenal gland. Okay, the pituitary gland, the adrenal gland. So first, we want to look at the pituitary gland. Okay, um, it has what? Two lobes. Okay, the pituitary gland. What I want you to know here is what? The anterior lobe and the what? Posterior lobe. Know all the hormones produced by the anterior lobe because it is only two hormones that are produced in the what? Posterior pituitary. You see what I'm talking about here? For you to try to remember which hormone is produced by what lobe, know that the posterior produces two. And I can easily memorize that, right? So any other hormone is produced by what? The anterior. That's all. So if you're asked on a question, the is prolactin produced by the posterior or the anterior lobe of the pituitary gland? You can know because you memorize what? That what? ADH and what? Oxytocin is produced by what? The posterior. Therefore, any other hormone is produced by what? The anterior. You get that? Okay. There are a lot of hormones. There are 7 hormones here: growth hormone, adrenocorticotropic hormone, thyroid stimulating, follicle stimulating, luteinizing, prolactin, and melanocyte stimulating hormone. So these are all produced by what? The anterior. So that's what we need to. We don't care if we memorize all of these or not, but we can memorize the two from what? Posterior, which is what? ADH and oxytocin. The other thing you need to know here is that you have to know what these hormones are responsible for. Okay? If you know what ADH does, if you know what prolactin does, if you know what TSH does, any question, you don't have a problem. Okay? All right. So we'll go into that. So when a patient shows up to your clinic, you're always going to take history. So these are the things you want to look for. Slowed growth. You will not understand this until we've gone over all the hormones and what they do. Then you know why when somebody has what? Accelerated growth, what type of hormone is causing that? If they are too short, what type of hormone is causing that? If they have what? A lot of, if it's female and that female has a lot of hair, what hormone is causing that? Okay. I see patients who come up all the time, should I say male, female, male patients who will show up to the clinic and they tell you they don't feel inside, they feel like they're in the wrong body. Okay. Therefore, they want us to give them hormones to let them become female. I'm not in that person's body. That's the way they feel. So what we do is we send them out to a psychologist who will counsel them for like 6 months to let them know the process that they're going to go through and the change that's going to happen to them if they really want to be what? Become female. So after they go through all the what? The counseling, then we put them on hormones and they become what? Right. So what the person feels inside, that's what they tell you. So you see a female with a lot of what? Facial hair. It's men or males have facial hair, right? But you find some females with that. What causes that? It's a hormone. They may be making more male hormone than female hormones. Okay, you can see women that have physical features like muscles and all that. Males make hormones that contribute to making more muscular features, but there are women who will be making those hormones also. Therefore, they have what? That's why when people try to say being gay or lesbian is, I don't try to go there. I don't want to talk about it because I'm not that person. I don't know how they feel. My role as an MP or as a nurse is to take care of the patient. You don't judge them. Okay. Back then, they used to even beat people that are lesbians and gay. They used to hang them and all that. Especially if you are Christian. I don't want to go talk about Christianity. So, especially if you are, they'll say, what is the spirit that is making you? You understand what I'm saying? So for us nurses, we need to learn from this that it's not that I cannot tell if somebody's faking it or it's real. But we know for a fact that hormones are produced by people that make them feel otherwise. Okay? So you need to learn this. So brain tumor, pituitary surgery, head trauma, nervous system infection, all of these things are stuff that you ask your patient and then you assess them based on these things. Even hypothyroidism. When the patient is hypothyroid, do you know what goes on with that patient? They're making they make more TSH. Therefore, they become hypothyroid. What are the symptoms of hypothyroidism? A whole lot. Okay, so when you see somebody who's gained weight, so much weight in maybe a year or two, you wonder what's going on. He or she's eating too much. It may not be food. It's because their thyroid hormone is not working the way it's supposed to. So they gain weight even when they don't eat that much. You get it? So it's a lot of factors. Pancreas. Somebody becomes diabetic for no reason, right? Because they may not be making what? There you go. Okay, so these are things you ask your patients when they show up. All right, so you review their system, look at their skin, because in Addison's disease, what happens to their skin? Hyperpigmentation. The skin becomes bronzed. So you talk about a whole lot of things. The person pees a whole lot. What is going on with the patient who's peeing all the time? It is a hormone. Okay, ADH can cause all of that. So we'll talk about all of the height and weight. When the person is real tall, they be making some kind of hormone. So these are the things you want to be looking at, okay? When we look at the patient who is older, age-related changes, what is going on? In a healthy older adult, the pituitary function remains adequate. The only thing you need to talk about here is that there is increased ADH secretion, okay? So you need to ask yourself, what is ADH? What does it do? And we'll come to that. Okay. So how do we diagnose all of these things? So when you check out page 914, 915, there are diagnostic tests and procedures. Okay. I want you to take a look at that and know what they do. Just read through this MRI, CT scan, blood studies, water deprivation test, gonadotropin, somatotropin, aldosterone, all of this stuff. Go over it, take a look at it. Okay. I know it's a lot. I'm not going to ask you anything about these tests. The main one I'm going to ask you about is going to be TSH.
What page is it on?
Come again.
What page?
914, 915, 916, 917. Okay, all the diagnostic tests. I'm going to ask you about TSH. I'm going to ask you about ADH. I'm going to ask you about PTH. And For a fact that, let me stop this quickly. Just give me a second here. Online, can you hear me?
Yes.
Okay, this is something I'm going to do today because I've gone over. This is the last exam we're going to do, right? So I'm going to do a little review over the questions today for next week. All right. So when we're done on time, I'm just going to go over the questions a little bit for everybody to. I don't know because you guys have not been doing well the way I expected you guys to do. I had to adjust the grades the last time. Did you guys see that?
Yes.
Your grades were
Appreciate
adjusted.
it.
Yeah, but if you look at your individual grades, they were raised. So I'm going to go over the questions at the end of the class. So if you stay, you might get some uh, tidbits on the exam. All right. So please go over these labs, get to know them because these are important for you to know. I mean, uh, especially the ones that I've mentioned: TSH, T3, T4, PTH, ADH. Okay, you should know what they do. All right. Okay. We all know about ELISA. What is ELISA test? What do we? Okay. All right. So now, all we're talking about when it comes to the pituitary is what? We're looking at the disorders of the pituitary. The first disorder we want to talk about is what? Hyperpituitarism. What does that mean? It means my pituitary is what? Overproducing. Okay? So if my pituitary, so I'm going to ask myself, what hormones are being overproduced in the pituitary? So it could be in the anterior or the posterior, okay? But the main ones that we rely on or we talk about is what? The growth hormone and prolactin. When we talk about the condition hyperpituitarism, what we want to talk about here is what? Growth hormone and what? Prolactin. Those are the two that hyperfunction when the person has the condition called hyperpituitarism. So know that it's just growth hormone and what? Prolactin. So what goes on? In that condition, what do we have? We have acromegaly. Okay, and what is acromegaly? It's a condition where the person has what? Thick hands and huge nose, huge lips, and huge face. Okay, that means what is growth hormone responsible for? That's what you need to know. Growth hormone makes you what? Big. So if I'm making too much growth hormone, I'm going to be like what? Shaquille O'Neal, right? If I'm making less growth hormone, because remember, your body works to keep you in what we call what? Homeostasis. So if you're not able to keep that balance, either you're making more or you're making less. So when you're a dwarf right here, I'm not a dwarf, so don't look at me like that. So when you're a dwarf right here, then you're making what? Less growth hormone, right? Okay. So what are the signs and symptoms of hyperpituitarism? You're gonna have problem with your vision, a lot of headaches, okay? Your hands and feet are enlarged, as I said already. Your tongue is enlarged, okay? Skin, liver, okay? Excess growth hormone impedes activity of insulin. So that person may have what? Symptoms of diabetes. Because growth hormone contains glucose, right? So these are some of the things you need to be taking a look at. So a patient shows up and they have all these symptoms. If you don't test them for all of this, you don't send them to an endocrinologist. These are some of the things you can never find out why this patient is always having what? Elevated sugars. Okay. So these are some of the conditions we diagnose people with when they show up. Okay. So how do we diagnose? As I said earlier, take a look at the diagnostic test and look at it. CT scan, MRI, okay? Because we're going to look at the pituitary what? Gland, correct? It's right in the brain. All right. So if the person is making what? Too much of the hormone, what do? We have to suppress the hormone, correct? So what do? We give medications. So know what somatostatin is, okay? Octreotide, sandostatin. So these are all what? Suppressants, and they bring down what? The growth hormone in the person. Okay, That person who is making too much growth hormone will be having what? Weight gain, right? Okay. We can also do what we call hypophycectomy, which is what? Surgical removal of the what? Adenoma, or the tumor that is making the pituitary overproduce. So what causes the pituitary to overproduce? It could be a tumor. Okay. So in hypophycectomy, how do we do that? We go through what? The nose. So it's important when the patient undergoes hypophycectomy, nursing care of a patient who has undergone hypophycectomy. It's important you know that, because these are the kind of questions inclines would like to ask you. After the patient has undergone hypophycectomy, they go in there. What are the teachings? What are the things you want to tell them? And this is in your books. You have to look at the nursing care of a patient who has undergone hypophycectomy. It's very important. Okay. They can also undergo radiation therapy. Okay. When a patient has cancer, they undergo chemotherapy and radiation, right? What are the problems radiation causes? Most of you should know this by now.
It kills whatever.
Exactly. So you need to know stuff like that, okay? So know that the patient who shows up with hyper overproducing of the pituitary, remember the pituitary produces what? Anterior hormones, posterior lobe hormones, right? But on the what? When it's overproducing, we are concentrating on two hormones. What are those? Growth hormone and prolactin. So in assessing a patient with hyperpituitarism, we think of what? Gigantism and what? Acromegaly. Okay? They're going to be big. Their faces, remember what acromegaly is? Okay, so what are the nursing diagnoses for such a patient? Disturbed body image, activity intolerance, chronic pain. Okay, all right. So there you go. Post-operative nursing care. It's important to assess neurologic status of your patient when they undergo that condition, that surgery that we're talking about. Okay, monitor their vision. Okay, after the what? Surgery. And also look up there, intake and output. Inspect nasal parking, because we're going through the nose and they'll be bleeding. Okay, that's very important. And then in the first few hours of the surgery, make sure you assess for what? LOC. What is LOC?
Low conscious.
Okay, very important. Okay.
On
So,
the slide before that, it said that they take adipose tissue to pack
pack the nose.
it so it doesn't, so you don't have spinal fluid leakage.
Where is that indicated at?
It was on the
One of the PowerPoints.
PowerPoint 18.
18, right?
Yeah. So
Okay, adipose tissue is harvested from the abdomen and used to pack the dura mater to prevent. That is when they're trying to prevent, because when they do this surgery, we're going in there, right? So there's the possibility that they can leak cerebrospinal fluid.
So you have two incisions.
Right. So we got to take some of the fat in here to pack it.
So during the recovery, you have to maintain two incisions, not just the one.
Yes. And then make sure that they are what? Seated upright. Okay. Or make sure the bed is semi-fireless, because when you lay down, that'll be a problem. So you always want to keep it up, because sometimes they may even be bleeding. Okay. So you tell them when they're going to cough to have what? Those are fundamentals of nursing, correct? And then, so splint, is that called splinting? What is it called? Stuff like that. So it's important you check bleeding, check LOC, okay? Take input and output, intake and output, inspect the nasal parking, okay? All right, so this will be the nursing diagnosis for a patient after they've gone through what? The condition or the surgery. All right, so the next thing we want, so now the first disorder we talked about is what? Hyperpituitarism, right? The next condition is what? Hypopituitarism. You see that? So in hypo, so if you want a picture of a patient with acromegaly, you can see that on 931. And then the surgical procedure that we talked about, hypophyseectomy, is also on 931. Okay, check these pictures out if it helps you. So the next thing we want to talk about is what? Hypopituitarism. So what does hypopituitarism mean? It means the person is making less what? Of the pituitary hormones. And we're looking still at what? Growth hormone. Therefore, the person is going to be what? Short. Okay? And so what's the first thing we want to talk about? Dwarfism. Okay? So if you're making less of the hormone, you're going to be a dwarf. Right? So if it's dwarfism, that means it occurs early and the person is as short as 36 inches. Okay? They may often have what? Delayed sexual maturity. They may not have, they may not be able to make what? Babies. Okay? They may look, the features look adult, like an adult, but they cannot, they may even have breasts and all that, but they are not what, fertile enough. Okay? Okay, so the next condition when it is about hypopituitarism is what we call pan-hypopituitarism, which is what? Where you have what? Muscle and organ wasting, okay? And you may have absence of what? ACTH. And ACTH is produced by what is it, the anterior or posterior? Anterior. And ACTH may be what? Affecting how you cope with stress. So when someone is always stressed out, somebody shows up to class and they're always mad at the world, nothing makes them happy, they're always stressed. You may think it's not. Probably they're not even making enough ACTH. So you see how all of these things, when you don't know medically, you might be thinking the person's got a problem. Okay, that's why we put a lot of people in certain hormones to help. Okay, so thyroid stimulating hormone will be depleted in what? Hypopituitarism, because we said what? They are underproducing. Remember, in hyper, it is overproducing, but we concentrate on only what? Two. Okay? All right. So the next thing we want to talk about is what? How we diagnose that. Still the same things. CT, we may draw blood to check the pituitary hormone levels. Okay? We can do a surgical treatment, hypophyseectomy. Okay, if surgery is needed. So you want to make sure you check the patient for what? Their well-being. Because the hormones that are produced by the anterior is involved in stress, well-being, how the person thinks and all that. So know the hormones that are produced by the anterior, okay? And you will be fine. All right, so the next thing I want to talk about here is what are the interventions that we need to know. Education is important. When the patient knows that these are the things that is causing my problem, then they will what? Go for a medical checkup. Some people may always be having headaches all the time. They'll never go, they'll be taking Tylenol forever and making their condition worse. It might be a little problem with their hormone balance, and that's it. Okay, so it's always important to go for a checkup. So know that a person who has hypopituitarism will be having problems with sexual function. So if you're a man and you cannot perform, it's important for you to do what? Go to the doctor. Let's find out what's going on. We can do a lot of tests that will come back to let us know that, hey, you're lacking such hormone, therefore this is what you need. Okay? All right. Now, let's go to the next disorder of the pituitary. Now we're moving on to the posterior. We started with the anterior, correct? And we concentrated on what? Growth and prolactin. Hypopituitarism, hypopituitarism. Now moving on to the posterior pituitary gland, which produces how many hormones? Two. We have what? ADH and what? Oxytocin. Here, we're only going to concentrate on what? ADH. So now the first disorder is called what? Diabetes insipidus. What is the opposite of diabetes insipidus? Anybody knows? SIADH. Syndrome of inappropriate antidiuretic hormone. I like to teach it this way so that you would understand what's going on. Because when you see hyperpituitarism, you know the opposite is what? Hypopituitarism. So what is going on here will be the opposite of what's going on down there. Now, I'm starting with the posterior pituitary gland. And the hormone in play here is what? ADH. So the first question you need to ask yourself is, what is ADH? What does it do? So that means, correct. So diuretic means what? You pee out, right? So antidiuretic means what? You retain water. So when the person has diabetes insipidus, okay, what is happening is they will be what? Peeing out excess dilute urine. So tell me, if they are peeing out excess dilute urine, are they making more ADH or less ADH? My online students, do you understand what's going on? Because you guys are not responding.
Yes.
I want to participate so I can hear what's going on. Okay. When I ask questions, please help my beautiful ladies and lady and gentlemen in here. Okay. Don't let them do the talking alone. So it means a person that has diabetes is, because guys, you need to know this. You're gonna get this on your NCLEX. I'm telling you, it's guaranteed. You're gonna have a question on diabetes insipidus, whether I like it or not. So a patient that has diabetes insipidus is what? Having excessive output of dilute urine. That means they are making what? Less ADH. Because ADH is antidiuretic hormone. So that means it's against what? What is ADH?
It's against diuretic. It's an antidiuretic hormone.
Okay, so antidiuretic means what? You would not be what? Peeing. So when you're making less ADH, what's going to happen to you?
Gonna slow.
So when you're making more ADH, what's going to happen to you?
You're retaining the water and able to.
You're gonna be big. You're gonna retain water, and you're gonna have healthy lung
You
health.
probably will retain if you're making more of it.
Okay. Are we confused or we understand what's going on? First, you need to know that ADH is what? When you make ADH, you hold on to water. So listen carefully. This is where the confusion starts. When you make ADH, you hold on to water. When you make less, then you pee more. Do you guys understand that? So in diabetes insipidus, the person is what? Peeing out. So they are making what? More ADH. So when you make less ADH, you hold on to water.
No, less ADH.
Antidiuretic.
Yeah, so less ADH, they expel it.
So less ADH, they're gonna pee. When I make more ADH, I hold on. You get it?
Yes.
Yes.
Okay, great. So now let's move on. So if you're able to understand this, then you should be able to understand diabetes insipidus. So in diabetes insipidus, the person will be peeing out a whole lot of what? Excess what? Urine. Okay? And the opposite is for syndrome of inappropriate antidiuretic hormone. That is SIADH. Okay? So antidiuretic hormone deficiency or inability of the kidneys to respond to ADH results in the excretion of large, okay? All right. So please know that, very important. So they pee out, so they become dehydrated. So when you are dehydrated, what are some of the potassium, sodium will be affected. Okay, all right. So we have, how do we diagnose that? How do we treat that first? We do IV fluid replacement. Okay, we may give desmopressin. Sodium intake will be restricted because the person is doing what? They're peeing out. Okay, so they become dehydrated. We get it?
Yes.
Yes.
All right.
Yes.
So you're gonna have thirst. You're gonna have what? Skin texture will be poor because they are peeing out. So know that DI means what? P P P P.
Fair question on the last slide.
Mhm.
It said that they would prescribe a thiazide diuretic. Why would you prescribe a diuretic when you're already peeing?
So think of what when somebody is peeing. What does thiazide diuretic retain?
Okay.
Say that again.
The trick, because okay,
It's okay. Yeah. It's one of the potassium.
right, right. Potassium sparing, potassium wasting. So think about that. So specific gravity of the urine. If the urine is light, remember it's excessive urine, you're peeing out a whole lot of urine, right? So what will be the specific gravity of your urine? Remember I talked about specific gravity before?
I mean,
If I'm peeing dilute urine out, what will be the specific gravity of a patient who has diabetes insipidus and they are peeing out dilute urine? What will be the specific gravity of the urine?
less than 1 point something.
What is the range for specific gravity, everybody? It's what? 0.100 to what? 0.3 or 0.01, sorry. 0.0100 to 0.300, correct? You guys got to know this because you can get a question on this. The specific, if the urine is dilute, it means the specific gravity will be low. So the specific gravity will be towards here for a patient with diabetes insipidus.
It'll be high.
Huh? Who's talking? Don't get confused. I am peeing out dilute urine. My urine is white
Right.
instead of yellow. What is specific gravity? Specific gravity is a what? The amount of substance that is dissolved,
The concentration.
right? The concentration.
So it'd be high.
My urine, if it's dilute, is not concentrated. If it's concentrated, it will be towards the 3.3. If it's dilute, it will be what towards what the 0.01. So DI will be what? Around here, less. And then SIADH will be what? High. So if I know all the signs and symptoms of diabetes insipidus, then I know the signs and symptoms of what? SIADH. Confused? When I'm peeing out dilute urine, right? My urine is white. When I'm peeing out yellow urine, then it's concentrated.
Yeah.
Because I'm just kind of confused.
Mm-hmm.
Because when I get test results back from my doctor, their range is 1 to 1.03 for the specific gravity.
You sure?
Yeah, look at it right here. Because mine's always 1 point something, and it's in the normal, it's normal range for them.
Check out specific gravity range. Check out specific gravity of the urine. And then you see the range. It's always 0.01 to 0.300. Anybody seen it?
Yeah, mine says 1.005 to 1.030.
That's what I just pulled up.
Okay. So even let's take it that is 1. What? Oh, you said it's 1. What?
005 to
005 to what?
1.030.
1.030. Okay. It's still the same.
Well,
One is less than 1.3. Okay. I have not always specific gravity to be 0.01 to, I don't know how, when they change it to 1 point something. So even 1 is less than 1.3.
Right.
You get me? So if you want to know about specific gravity, the less, that means it's dilute. The higher concentration will be more concentrated. Okay? So on the question of specific gravity, you should be able to get it when you see the numbers. Okay? The lesser the number, the less the concentration is. The higher the number, the higher the concentration of the urine. Okay? All right. So the interventions are right there: anxiety, disturbed body image, deficient fluid volume, activity intolerance. Okay. Now, this is the opposite of what? Diabetes insipidus. So in here, the person is making what? Water imbalance related to an increase in what? ADH synthesis or secretion. So in what? In diabetes insipidus, we're making what? Less what? ADH. In syndrome of inappropriate, we're making more ADH because we said, what does ADH do? ADH holds on to water. So if I'm making more ADH, then I'll be holding on to more water and I'll be bloated. If I'm making less ADH, then I'll be what? Peeing out. I cannot hold the water. That is what ADH. So it's a hormone. Remember in the beginning, I said you need to know what the hormone does to be able to figure out what's going on with the patient. For a man, let me digress a little bit. For a man who's making prolactin, you ask yourself, what is prolactin for? There you go. So when you start seeing a man with gynecomastia, they have large breasts and they're having milk coming out of their breast. What are they making? Making prolactin, which is more for women than for men. You see that? So it's the same thing. No, for what does ADH do? ADH makes you hold on to water. So when I'm making less ADH, then I'll be what? Peeing out. So in SRADH, I'm making more ADH. Therefore, I'm holding on to water. Therefore, what happens to me? I am going to be what? Bloated, okay? I'm going to be bloated. I'm going to have less sodium because remember, I'm not peeing and the water is diluting my system. You see that? So you can easily what? Tell the signs and symptoms. So if you know the signs and symptoms in DI is the opposite for what? SRADH. So draw a table, put this on the left, put this on the right, write down the signs and symptoms, and you know them. You only have to know one and you know the other. Okay, so there you see right there. When ADH is elevated, despite normal or low serum osmolality, kidneys retain excessive water. So you see, so hyponatremia. Would you find hyponatremia in DI patient or SRADH patient? And I need explanation.
Yeah.
What is hyponatremia? Low sodium. Are we going to find low sodium in DI or SRADH? And you have to explain your answer.
Would be DI.
I could find it.
Would be DI.
Because you're peeing it all out in one, and then the other one is being diluted by the retention of the water.
Because sodium follows.
Remember, the signs and symptoms of DI will be the opposite of, so it cannot be both, right? So now I want you to think, when in DI, I'm making what? Less what? ADH. Therefore, I'm going to be peeing out, right? I pee excessive water. Therefore, my internal system is what? Hyper, more sodium because I'm losing water.
Okay.
But in SRADH, I'm retaining water. Therefore, my internal system is going to be what? Diluted. Because I'm holding on to water. So what will be the urine concentration of a patient with SRADH? Concentrated, because they hold on to the water. They're not peeing out. It will come if you guys sit down and read and you write it out. It comes naturally. So when you don't understand, now don't be worried so much because it's a little bit confusing. I know. First is for you to know what ADH does. ADH makes you what? Hold on to water. So when you make less of it, remember, it's hormones. You have to be balanced out. So if you're making more or less, then there's going to be a problem. So here in DI, the person is making what? Less, because we know ADH makes you hold on to water. So if you're making less ADH, then you're going to be peeing out. You're going to pee all the water out. Therefore, your system becomes what? Dehydrated. So in SIADH, the person becomes what? Overhydrated because they're holding on to water because of the ADH. They are making too much, keeping too much of the ADH. Don't be confused, people. Okay? I know this is confusing, but when you sit down and read and make your little notes, it will come. All right, people? So look right there. The urine in SIADH is what? Concentrated. The urine in DR is dilute. Therefore, specific gravity in what? DR is what? Low. The specific gravity in SIADH is high. Everything is opposite. So when you get a question, that's what they're gonna ask you questions like that. Urine concentration. It's a person who's peeing out a whole lot. What condition do they have? Diabetes insipidus. Is their urine concentration going to be high or low? You know, it's going to be low in DR, high in this. So a person with SIADH, they're holding on to water. How they become big, they become, you see what I'm talking about? So think and you can get the answer. Okay? All right. So the next thing we want to talk about is what? So what are the signs and symptoms of that? You're going to have what? Muscle cramps and twitching because of what? You're going to have low, you're holding on to water. Everything is dilute. Your sodium is going to be low. Your calcium is going to be low. That causes what? Muscle cramps. Okay? That can even affect your heart and all that. All right? You're going to have seizures. Okay? You're going to have water intoxication because you're holding on to too much water.
But I have a question.
Yes, ma'am.
On signs and symptoms, it says weight gain without edema. Why would edema be present?
Weight gain without edema, because the moment you start having edema, it's got to do with your heart.
Okay.
You understand? At this juncture, your heart is not affected. If your heart is affected, that's when you have your lower extremities having edema because the blood cannot be returned. Your veins become weak. They cannot return the blood to the heart. Remember what? Oh, we haven't done that. We'll do that. When we talk about the heart, okay, the circulation, you will realize that blood flow is in the veins. The veins take blood towards the heart, and the arteries take blood away from the heart. That's what we say what? Venous thrombosis, you got venous blood return. It's all down here. So that's why it says edema without, okay? So in a person that has SIADH, see what we tell them, restrict fluids. So it's not all the time that you think a person that has kidney problems is being told to what? It could be what? SIADH. And another thing, they have what? Water retention without edema. Is that what you said? Because it's not the kidneys either. When you have kidney problem, also you have edema of the what? Peripheral edema. Because kidneys what? Filter the blood and they excrete what?
Waste.
They excrete the urine and the fluid on you. So if your kidneys are failing, what's going to happen? You're going to retain, have edema, peripheral edema. If it's down here, it's your heart.
So you wouldn't need dialysis to treat this?
No, here we don't need dialysis because the kidney is functioning. The problem here are hormones, which is what? ADH, which is not effectively producing the way it's supposed. It's not balancing out. Therefore, what we do to this patient is what? We restrict fluid. We tell them not to what?
Don't drink water.
Exactly, and we increase sodium intake.
Increase?
Yes,
Yeah,
because remember, yes,
sodium's diluted.
sodium is diluted. You get that? It gets beautiful when you understand it, okay? So you want them to take more sodium. Okay, so this is what the kind of assessment you want to do, okay? Muscle strength and all that stuff, okay? Weight gain, intake and output, urine specific gravity, okay? Because I try to explain the urine specific gravity because of what? You're going to have that on your test, on your NCLEX. So people don't really understand that. So I try to base. But when it comes to seizures, if they ask you why is the patient with SIAD having seizures, what would you say?
Uh,
Calcium.
calcium.
Yes. There you go. Magnesium. Because they're holding on to water and all those what? Electrolytes are what? Diluted. Get it?
On the
Great.
slide, on the slide before that, it was talking about the two medicines to give.
Yep. Patients who cannot adhere to fluid restriction with high sodium intake may be given demiclocycline or lithium carbonate. On the medication part, I don't really know why they give that. All I know is that we give patients lithium carbonate, which is a salt. So we're giving that salt because we need what the person is dilute in what?
The
Right.
sodium's low.
There you go. So lithium carbonate is a salt. So that's all I know about that. Okay. Are we okay online?
Yes.
And remember, we're talking about mental status. So these are things you need to think about. Mental status change happens when you have electrolyte imbalance. Get that? So now we've talked about what? Hyperpituitarism, hypopituitarism. Diabetes insipidus, the opposite what? SIADH. Okay? Don't forget, people. So what are the interventions? Risk for injury, excess fluid volume, ineffective health management. Okay. So now let's move. We're moving on to what? The adrenal glands. Okay. Moving on to the adrenal glands. Okay. When it comes to adrenal glands, all I want you to remember, okay, is what? It's got to do with steroids. Can you remember that? Steroids, steroids, steroids. And what are steroids? What do they do to you? If you can remember that, you're fine. Think of a patient who's taking steroids. What do they become? Big. They get moon face, buffalo hump. Okay? So when you think about that, and then know that anywhere steroids or cortisol, know what cortisol is? Cortisol is part of what? The steroid class, okay? Anywhere cortisol goes to, sodium follows. If you can remember that. Okay? So the person who's having those are the things you need to remember. Wherever cortisol goes, sodium follows. Okay? And then what is the sodium one? Wherever what? Sodium goes, water follows. Right? Okay. So now you can think why the person becomes big. Okay? All right. So also know that norepinephrine and epinephrine is also what stimulated, okay, when it comes to the adrenal gland. So we're going to find out why. Now, the cortex, the adrenal cortex, produces what? The steroids. That's all I want you to remember here, okay? And steroids are what? Hormones, mineralocorticoids, glucocorticoids, androgens, what? Estrogens or estrogens, okay? Those are all what? Hormones. And what are they responsible for? They're going to make you huge. All right. Now, look at the other. We also have what? In the adrenal gland, we have what? Mineralocorticoids. We have renin, angiotensin, and aldosterone being produced there. Okay. So any excess of this, we need to find out what's going to happen to the patient. All right. When it comes to angiotensin and aldosterone, it causes what? Sodium and water retention. Okay. So when the person is making a high amount of aldosterone, they're going to have what? High blood pressure. So we're going to be taking a look at all of that and find out the conditions that what happens for a patient that is making too much of the adrenal hormones, okay? And I stated that, well, remember, it's all about steroids, right? Okay. Now, sex hormones are also produced by the what? Adrenal glands. Okay? And the primary function of your sex hormones is to what? Masculinization. Okay? In especially postmenopausal women, the adrenal cortex is the primary source of what? Endogenous estrogen or estrogen. All right? So when the patient shows up, just collect the history that you need to collect. Okay? Find out whatever is going on with them. Ask as many questions as you can in terms of depression, nervousness, confusion, sexual dysfunctioning, skin pigmentation. Okay, review their systems, find out how they perceive health. Okay, look at their skin color, what is going on, and we're going to find out why we're asking all these questions. Okay, you talk about height and weight when you do your physical examination. Age-related changes, what goes on when the patient is having problem with the adrenal glands. Okay, all right. Now, let's look at adrenal hypofunction. So that means if your adrenal gland is underperforming or underproducing the hormones, what is happening to you? So what did we say the adrenal gland is responsible for? Steroids. So if I'm making less steroids, the condition is called what? Addison's disease.
Mhm.
Okay, and what? Exactly. Replaced with steroids. So the condition when the adrenal gland is underperforming or underproducing, we call the condition Addison's disease. So all you have to know is what is going on. They are making less cortisol, less aldosterone, less steroids. Okay? And the opposite of Addison's disease is what? Cushing's. What is Cushing's disease? I become bloated. In Addison's disease, become what? Skinny, small, hyperpigmentation, and you will always get this hyperpigmentation on your exam. Anytime you see hyperpigmentation, it's called what? Addison's disease. All right, it is always going to be on your test. Okay, so cortisol production will be what? Affected. Androgen production will be affected. All the steroids, that's got to do with steroids, are low. Okay, okay, so insufficiency of adrenocortical steroids, defects associated with the loss of mineralocorticoids. So it's all about the corticoids. Okay, they are underproducing. So what happens to the person? That person has what we call skin hyperpigmentation. Okay, skin hyperpigmentation. It's in Addison's disease. Okay, just remember that one, and you will be fine with any question. When they talk about the person has skin hyperpigmentation, making less cortisol, less steroids, you know that is what? Addison's disease. Okay, then let me forget about this right here. One thing also that you need to remember is the fact that the person can go into what we call Addisonian crisis or Addison's crisis if you what? Stop steroid what?
Immediately.
So that is the reason we say what? Taper off when the patient is on steroid replacement, like syndrome. Correct?
Yeah.
So you check, you see right there, precipitating factors of adrenal surgery, pituitary distraction, abrupt withdrawal of what? Steroid therapy. So make sure you taper off. You never just stop it like that because they'll go into what we call Addisonian crisis. And Addisonian crisis is what? Hypotension, tachycardia, dehydration, confusion, hyponatremia. So you see what is going on. Remember I said what? Wherever cortisol goes, what follows? Sodium. So do you see that the patient with Addison's disease, they are what? Hyponatremic because they have less cortisol. So you see how you can break this down and write all the signs and symptoms on Addison disease, and it's opposite for what? Cushing's disease. So please, I'm imploring everybody, you have to do that table. Juxtapose this disorder against this, and you're fine. So write them out. Addison's, and then what? Cushing's. What's the other one we talked about? DI and what? SIDH. Hyperpituitarism against what? Hypopituitarism. And you write down the signs and symptoms. So if they ask you, in what Addison's disease, we know it's steroids. And I said, wherever cortisol goes, sodium follows. So is the patient with Addison's disease having hyponatremia or hypernatremia? Hypo, because remember in Addison's, the person is making less what? Cortisol, less steroids. Remember that. And wherever there are steroids, there are small salts. That is why patients on steroids are all what? Huge. Their face is swollen. Their back hump is what? Bumped up. We call it a buffalo hump, right? Then their abdomen is what? Huge. Because they what? Have salt, have water. So look right there. They have what? Hyponatremia, dehydration. This is Addison's. And then remember, wherever sodium is, potassium is going out. Potassium is going the opposite way. So if you know that it's hyponatremia in Addison's, what will be kalemia issue? Hyper. You get it? Wherever sodium goes, potassium is leaving. They go in opposite direction. Cortisol, wherever cortisol goes, what? Sodium follows. Wherever sodium goes, water follows. You get it? So when you know these statements, so please write these down. I said, how did I start? I said, what? Wherever cortisol goes, sodium follows. So when you are giving a lot of steroids, know that you can be hypertensive, hyper. When you're giving steroids more. I said, wherever sodium goes, potassium is leaving. So anytime someone is hyponatremia, they're going to be hyperkalemia. Are you guys getting me online?
Yes.
Great. So you see right there.
Yes.
And what? See right there. So hyponatremia, confusion, tachycardia, hypertension, and hyperkalemia. And always potassium goes with calcium. So when you have hyperkalemia, you're going to have what? Hypercalcemia. It's a lot of information. I know it will come slowly. The only thing that I ask is keep reading. Okay? Keep reading and you'll be fine. Okay. So basically that's it for Addison's disease. How do we diagnose that? We do lab studies, electrocardiogram, because know that if you have low sodium, it will show when you do blood draw. Okay, high potassium can show, too much potassium can kill you, right? Okay, your heart will stop because of what? Potassium. What else would I talk about here? So how do we treat Addison's disease? Just like you said, we what? Replace with what? Glucocorticoids and mineralocorticoids. So because they are low in what? The corticoids, steroids. Just think about that. Okay. All right. So the next thing we want to talk about here is what? Weight loss. Because what? Less steroids. So they're losing weight. The salt craving because of what? Hyponatremia. Have nausea, vomiting, abdominal cramping, diarrhea, muscle weakness because of what? The calcium that is all high. Remember, if you have calcium imbalance, it's all muscle problems still. Whether calcium is high or low, you're gonna have muscle problems, muscle twitching, cramps. Okay. So right there, bronzed skin is what? Patient with Addison's. Okay, is the same as what? Hyperpigmentation. And basically, this is talking about Caucasians. Okay, when they have the bronze skin, think of a patient with what? Addison's disease. All right, they're gonna be hypotensive because they're losing all the water. They become skinny, no salt. Okay, okay. So this is your nursing diagnosis right there. So now this is the second one. This is the opposite of what? Addison's.
Yeah.
So who can tell me what's going on in Cushing's? Without, as long as you know Addison's, they do what? Too much what?
Weight. They gain weight in Cushing's.
Yes.
They gotta have hyper.
Too much steroids. Thank you. Think of Cushing. How does Cushing look like? Foamy, right? Exactly, like a Cushing. That's what we call Cushing's disease. Okay? So therefore, the person is pumped up. That's how I always remember it, like Cushing. Cushing is formed when you sit on it, it bounces, right? So that's how I remember it's all bloated up. They have too much steroids. So the what? They have, and I said, what? Wherever cortisol goes, sodium follows. And I said, wherever sodium goes, potassium is leaving. Wherever water goes, wherever sodium goes, water follows.
Oh, potassium.
Can you remember this?
Yeah,
You will be fine. Therefore, a patient with Cushing's is gonna have what? A lot of steroids, a lot of sodium, so they're gonna be hypertensive. They have a lot of water,
Yes.
okay, but they're gonna be hypokalemia, hypocalcemia.
Yeah.
See how you figure this out?
Mhm.
Easy. So the opposite of what? Addison is what? Cushing's disease. And that's what you go through. Less steroids. Okay? There you go. So the pathophysiology, you should be able to understand that. So we have person with what? Hirsutism. What is hirsutism? There you go. Okay? They're going to have hypertension. Okay? Menstrual disorders. Okay? These are the main things you want to remember. Truncal obesity. Okay? They got big belly. Okay? Protein wasting. Have you ever seen a patient with what? Let me show you a picture. I believe there used to be. Look on page 944. Clinical manifestations in a patient with Cushing's syndrome. Look at that. If you can always remember this picture, you will always what? Remember what Cushing's syndrome is, or Cushing's disease is.
What purple stripe on the abdomen?
You see, you like a mark when people become fat and they try to lose the weight. You see some, I call a stretch mark. I don't know.
Yeah.
That's it.
Okay.
You see, when they try to lose the weight, you can see some marks right down there.
I mean, I got it.
There you go.
Half of those
I
stripes.
got it too, brother. So there you go. So facial fullness or moon face. The face is huge, right? They got osteoporosis. That's one thing I want you guys to remember. Osteoporosis. It's a common question. People that are on what? A lot of steroids, they get risk for osteoporosis. Remember that. Fracture, they fracture easily. People on steroids. So Cushing's disease, these are the things you want to remember. Okay. Remember we said hypokalemia. Therefore, what would be for sodium in Cushing's? What would be the sodium concentration? Would it be hyponatremia or hypernatremia? Sodium. I'm talking about sodium.
Be hyper.
You'll be hyper because I said wherever potassium is, sodium is out. So if it's hypokalemia, then it's what? Hypernatremia for the patient with Cushing's. Can you remember that?
Yes.
Because it's always, I said, sodium and what? Potassium are always fighting each other. Wherever one goes into the cell, the other goes out. Okay? So if the person is what? Hypokalemia, what will be calcium?
Calcium would be the same as potassium.
Calcium be
Good.
low too.
Calcium will be the same as potassium, so also hypocalcemia. They're gonna ask you these questions. Okay, so you got to know them, but know that the what, the moon phase and all that stuff. You need to remember them. Okay, truncal obesity and all that stuff. So how do we that CT scan? We can also do the 24-hour urine collection. You all know what 24-hour urine collection is, right? Remember that? Okay.
Yes.
So here they're making too much steroids. So what do? We do the low dose dexamethasone suppression test. Okay, I want you guys to read about that. The dexamethasone suppression test is a steroid suppression test. So if we cannot suppress the what? The steroid, that means what? They got what? Too much steroid. Exactly. All right. So you see right there, hypokalemia, hypernatremia, hyperglycemia. Because remember, when a patient is receiving steroids, what do? We do glucose check or glucose what? Test for glucose because the steroids make them what?
Hyper.
Hyperglycemia. So they are false diabetics, right? So we check their blood glucose. Can you remember that too? It's very important. This is another question you can be asked, okay? When they are when they have Cushing's disease, they have too much steroids, know that we check their blood glucose.
And the glucosuria, is that glucose in the urine?
Glucose in the urine, because if if you're diabetic, what happens? You pee it out. Okay? All right, lovely. So what is the medication we give? That's right there. And we can also do radiation and we can also do surgery. Okay. All right. So this is the These are the uh, interventions or nursing diagnosis. You can read about that. Okay. So this is the pre-operative care of the patient that is undergoing adrenalectomy because they're having problem with the adrenal gland. Okay. Know that. Check vital signs. Check for level of consciousness. Okay. Uh, use strict aseptic technique. What else would I talk about? Know that there's a condition that is also part of the adrenal gland. We call that pheochromocytoma. Okay. This is a tumor of the adrenal medulla, and it causes what? Excessive production of catecholamine. Anybody remembers what catecholamines are? Flight and fight.
Oh, yeah,
Remember that?
yeah, yeah.
Norepinephrine, epinephrine, adrenaline rush. Remember that?
Yeah, I was thinking adrenaline.
Right, exactly. So when that happens, when you're ready to fight somebody, what happens? All your stuff is up, right? You get hypertension, hypermetabolism, hyperglycemia, okay? Excessive catecholamine secretion, okay? So know what that is. All right, so let's take a 10-minute break, and then we'll finish up with the second part, okay? All right, let's finish up with thyroid and parathyroid disorders, okay? So in this chapter, I'm on page 950. You've got to do the same thing. So you take one disorder, you juxtapose against the other. So hypothyroidism against what? Hypothyroidism. Hyperparathyroidism against hyperparathyroid. So that's the same thing. We're just going to learn the disorders and then that's it. All right. So can you guys see my screen?
Yes.
Yes.
All right.
Yeah. Yes.
So now we're looking at the thyroid gland. Okay. You need to know that it is located on the anterior of your neck. Okay. It's got two lobes and it's right beside the trachea. So that makes it very dangerous when it comes to what? Airway. Okay. Very, very bad. So when you have problem with your thyroid and we have to go in and remove it, it's a big problem. Did something happen? Looks like my screen went off.
You switch back to the other slide.
How did that happen?
Other tab. Because you got two of them open on there.
Okay. All right. So what you got to know here when it comes to the age-related changes in the thyroid function is that there is increased incidence of thyroid nodules when you start to age. And you will see that the incidence of hypothyroidism increases with age, especially among women. Okay. So most women have what? Hypothyroidism when they start to age. So for assessment of a patient with thyroid disorders, you want to talk about what sexual function, hydration, bowel elimination, okay, tolerance of heat and cold, which I'll explain why, okay. You have to do physical exams, check vital signs, height and weight, head texture, and all that. Okay. Now let's move to how we diagnose a patient who comes in with what? Hypothyroidism or hyperthyroidism. It's easy, okay? I want you to see right here. No. Oh, can you guys see the blackboard, the board, the whiteboard?
No.
Oh, sorry, I'm sorry. I had this video off. Can you see now?
Yes.
Okay. What I want you to remember is what? We got TSH.
Can you move it up just a little bit? Like
Move it
it's
up.
down low.
Down, right? Okay, sorry. Is that good?
There you go. Thank you.
We got TSH, 3T, and then T4, okay? So T3 and T4, they go together. TSH is on its own. But on your test question, they're going to ask you how to diagnose, what test would you do to diagnose hypothyroidism or hypothyroidism? The answer should be this, TSH, okay? But know that If this is increasing, okay, this is what? Decreasing. TSH decreasing, T3, T4 increasing. They are always opposite. We will not talk about compensation here, but that is how they increase in terms of, these are different, all different hormones, okay? It's not about compensation though. It's
I
about
can't see that.
okay? So when TSH is increasing, it equals what? Hyperthyroidism. When TSH is decreasing, it equals what? No, sorry guys, it's the opposite. Sorry people, this is hypo. When TSH is increasing, it's hypothyroidism. When TSH is decreasing, it's hyperthyroidism. Do you see what I'm talking about here? And for this is directly proportional to the diagnosis. So when T3 and T4 are decreasing, it is what? Hypothyroidism. When T4 and T3 are increasing, it is what? Hyperthyroidism. Can you guys see the board?
Yes.
It's important to try to know this. Because if you know this, there's no test question on how to diagnose that will beat you. Remember that TSH is opposite. T3, T4 is directly proportional to the diagnosis.
What's the difference between free T4 and T4?
Good question right there. It's just hormones that have been discovered in terms of hypothyroidism and hyperthyroidism. I don't really know much about that in terms of chemistry. Okay, I'm only a nurse practitioner and I only be on the surface diagnosing people. When I check their blood, I would let the pharmacist or the chemist tell them they really want to know more about T3, the differences.
No, the free T4.
Yeah, the free T and the free the T4.
So, like, is there a test that you would do for the free T4?
Yes, there are different tests for free T4 and then T4, TSH, and T3.
So if your free T4 is different than
Usually there's a reason why the free T4 and the T4 and the T3 are done, especially when we have what we call clinical hypothyroidism and stuff, when your TSH may be normal, but the T4 will go low.
okay.
So sometimes the patient with clinical, we don't put them on any medication. So there's a reason for all of those, okay? But what at this level, just concentrate on TSH, T3, and T4, okay? And know that if T3 and T4 are increasing, the person has what? Hyper, when they are increasing. So guys, remember that. When the T3 and T4 is elevated, the person has what? Hypothyroidism. When the T3 and T4 are low, the person has what? Hypothyroidism, okay? And when the TSH is increased, the person has what?
Hypo.
Correct. What's this? Zoom. Somebody sign me out. Are you guys on there?
Yes.
Yeah, I'm here.
What did somebody sign me out?
Yes. No.
I hope you guys are still up there.
Yeah, I can hear you.
Yes.
I can see it.
Oh gosh, somebody trying to log in. Okay, so please know that. So now the question is, since you already know this, on a test question, if you see that the person has TSH, what is TSH level? Anybody knows?
I don't know.
0.5 to 5.0. I don't think they're going to ask you, but please know it. Is it in your books? Okay. 0.5, it's easy to remember. 0.5 to 5.0. Okay. So if the person's test results come back 0.1, what is it? If the TSH is 0.1, what does that mean?
Hyper.
So the person is hypothyroid. Exactly. So the person has hyperthyroidism. So for a patient with hyperthyroidism, what do we do? Remember, what do we do to that patient? Beautiful. We give them anti-thyroid drugs. Good job. Okay, so when the person is hyperthyroid, we give them what? Anti-thyroid medication, like what? PTU. Okay, what is another medication for that? We'll come to that. Okay, so when the patient comes in, okay, and the TSH comes back as what? 5.5. What condition do they have?
Hypo.
Exactly, hypothyroidism. If you can remember this, please, you don't have a problem. They have hypothyroidism. So this is where, so remember, when the TSH is increased, they have hypothyroidism. Therefore, what do we give? Synthroid. So you see how confusing it is? Do you get it? Good. So if the person has hypothyroidism, we give them synthroid. If they have hyperthyroid, we bring down the thyroid, we give them more anti-thyroid. But look at the way the numbers go. So please know that when TSH is elevated, the disease is hypothyroidism. If TSH is decreased, the disease is what?
Hyper.
Exactly. If you can figure that out, on my exams, all I had to do was write this on paper. So what I do is I write down what I need to remember before I start any exam. If I need to remember all my lab values, I write them down. TSH, because when you start the exam, the anxiety alone takes away everything out of your memory. So the best thing to do before you start the exam, write down whatever you got to write on your scratch piece of paper. And then start the exam. Because when you're given a question on hypothyroidism, when you read the question, you get confused because your anxiety level is high, even though you know it. So if T3 is elevated, what is the condition? It's decreased. What is the condition? Hypothyroidism. Okay? If T4 is elevated, what is the condition?
Hyper.
There you go. So we should be able to figure this out easily. And you're going to have questions on this, all right? When do we give synthroid? When the T3 is what?
When T3 or TSH.
TSH, when TSH.
When TSH.
Talking about TSH.
But T3 would be low.
T3 will be low, T4 will be low, TSH will be high.
Yeah.
Wonderful. Good job, people. Try to remember this and you'll find, okay? All right, so that's the main thing about that. So, what are the characteristics of what? Hyperthyroidism. Okay? So in hyperthyroidism, it's got to do with metabolism, okay? Metabolism. What is metabolism? There you go. So if you are hyper, that means you break down food easily. So if you can remember this, that means that person will be skinny. They will have diarrhea. Temperature will be high.
With their personality.
Exactly. Everything is up. Can you think about it now? Okay, it's hormones issue here, okay? So everything is up. They're gonna have diarrhea. They're gonna be losing weight. They eat and they break down easily. Okay, they got tachycardia, hypertension. Everything is up. Just remember that in hyperthyroidism. Okay. All right. So we have a condition called what? Nodular what? Goiter. It's often seen in women's 60s and 70s. It is when you have what? Your thyroid nodules are what? You see people with big necks, okay? They got goiter. I had a girl at work I saw her neck was bulging, and I told her, hey, when was the last time you've been to your doctor? She said, oh, I don't go to that. I said, yeah, you got to go because you're having problems with your goiter. It's swollen. When she went, she came back, she thanked me forever. They had to do a surgery and take her because it was so elevated, and they put her on Synthroid then. They took out all her, thyroid gland. So when they take out your thyroid gland, you got to remain on what? seen throughout for the rest of your life because what? The production, the gland that makes it is no more there. Okay? All right. So what are the signs and symptoms of what? Hyper. It's easy to remember. Everything is fast. Metabolism is fast. Therefore, what? Weight loss and nervousness, restlessness. Look at all of that. Sleep disturbance, personality changes, weight loss. So, but the main things you can remember is the weight loss, diarrhea, heat intolerance. Okay, somebody who cannot stand the heat at all. That's me right here. Okay, but it's funny I'm not skinny and I'm fat. Okay,
That's why I say that I can't stand the heat.
yeah, I can't. So excessive perspiration, changes in menstrual and bowel patterns. So for the bowel patterns, know that everything is what. When they ask you what will be the person's changes in menstrual pattern, would they be bleeding more or less?
Or
What about bowel patterns? Are they going to be what? Diarrhea. So you see how you can easily juxtapose this with what? Hypothyroidism. And now look, they have what we call exophthalmos, the bulging eyes. Okay? And the lady which I talked about, when you see her eyes. So I was asking, didn't you realize there was some change? She said she's been like that for a long time, so she didn't know. So that's it. Exophthalmos, light sensitivity, visual acuity decreased. You can't see very well, okay? Tachycardia, blood pressure is increased. So guys, you should be able to remember this easily, okay? When you don't take care of a patient that has hyperthyroidism, the complication is what we call thyrotoxicosis, okay? Where you have excessive what? Thyroid hormone what? Levels. Therefore, you have tachycardia, hypothermia, everything is what? There you go. Okay, so please remember that's, see how easy thyroid is? So that's the diagnosis, and I've told you that already. So, Graves' disease is another name for what? Hyperthyroidism. Do you hear that? Don't forget, they're going to ask you that. So if you don't see hyperthyroidism, know that it's the same as what? Graves' disease. Okay? So when you have Graves' disease, what do we give you? What medication? We give you anti-thyroid medications because you are hyperthyroid. So we got to give you medication to bring it back to normal. Okay? All right, we can also do the surgery, which we call subtotal thyroidectomy, where they go in and remove all. So what's the number one priority for a patient who has undergone subtotal thyroidectomy? Who can tell me why? What's the number one priority? No, what after the surgery, what is number one priority for that patient? Airway. Why? Beautiful, because it's right here at the trachea. So breathing and circulation is gonna be number one. All right, and this is a test question. Okay, so the person who is what? Hyper, heat intolerant, they can't stand the heat. Okay, they have diarrhea, they have weight changes. Okay, what else? Hypothermia, disturbed sleep patterns, risk for injury, and all of that stuff. Okay, so when they undergo the surgery, we got to make sure that we take care of them because airway is number one, right? And then when they do the surgery, remember what? They're gonna be bleeding at the back of the neck. That's another thing you need to remember, because they'll be laying like that, and we will not see that the incision side has blood, but you look behind the neck. That's a trick question for on your NCLEX too. Okay, because the blood will be going down from here to the back of the neck.
I guess it would be pulling in the back.
Yes. Okay. So very important. When they start to swallow, anytime, then they start to swallow a whole lot, they may be bleeding.
It'd be like the same
Yes.
signs as when they have tonsillectomy.
There you go.
The frequent swallowing.
Frequent swallowing. Think about that. Yes. So ineffective airway clearance is number one. Okay. Okay. Now let's move on to hypo. Okay. Remember, I'm trying to break down everything for you. Make sure you read your books for the little stuff that I don't touch on. Okay. Remember, the teacher will not go over everything, but I'll go over the main things. It's up to you to be able to what? Read as much as you can to get extra information. Okay. All right. So in hypothyroidism, it is inadequate secretion of what the thyroid hormones. We call the condition what? Cretinism. Okay. That is, if it's not treated early, okay, and it happens during infancy, it's called cretinism. And then if you grow normally, okay, it's cretinism rather. So we have a condition called myxedema. That's when you have facial edema from severe long-term what? Hypothyroidism. Okay. All right. So what are the causes and risk factors? If you have too much what? You've been treated for hyperthyroidism. Remember, you're being treated for hyper, but you can go into hypo because the medication that you're given can bring you down. That is why we always do what? Lab work. So after every 6 months, every 3 months, you got to go for checkup. So when it's low, we have to stop the medication. You get it?
Would you stop it or would you titrate it down?
If it's low, I will stop it and then come back again in 2 weeks or 3 weeks or 4 weeks. If it's gone low, then I'll have to what? Put you back on it. Because you want it to be what? Homeostasis. There you go. Okay. So, what else am I going to talk about here? Signs and symptoms. It's the opposite of what? Hypothyroidism. Swelling of the lips and bruising. They become thick, hoarseness, generalized non-pitting edema, facial edema may seem slow. They've gained weight. Okay. They have constipation. So all the things we talked about in hyper will be opposite in what? Hypo. They can't stand cold intolerance. You get the point? So everything we talked about is opposite. So please remember that. It's easy. So when the person is hypo, that's when we give what? Synthroid. And how do we stop synthroid? We taper it off. See that?
The myxedema coma.
Uh-huh. Myxedema coma is when you have hypothyroidism and you do not take care of it. The complication is the myxedema coma. Get it?
I thought myxedema was swelling of the face.
Yes, well, we're talking about myxedema coma.
Okay. So you'd have the swelling of, or the edema in the face, but
Yes.
you would also go into a coma.
The myxedema coma is the complication of it. Just like thyrotoxicosis is a complication of hyperthyroidism. Okay, so the complication of hypothyroidism is the myxedema coma. Okay, so let's take a look at that. So the person with what? Activity and temperature intolerance, voice, bowel elimination patterns. They become constipated. Okay, they cannot. They always slow. They gain weight. Okay, hypothermic, constipation, impaired skin integrity, self-care deficits. All right. So we've talked about goiter, and the causes are lack of what? Iodine. Okay, lack of iodine. And you can get this on your test. Lack of iodine causes. So know that one. So we can also do the same. What? Surgery. Okay. Or we can give them what? Synthroid. Okay. The goiter, we can remove it. We do surgery and take that out. And that patient may be on Synthroid for the rest of their lives. All right. So we do the total thyroidectomy. And so a patient know how to take care of a patient who has undergone total thyroidectomy. And it's in your books. So please, I want you to know that. Okay. All right. So the next one we want to talk about here is yes, one thing I also need to mention is that when you do the surgery, okay, when you do the surgery, removal of the what? The thyroid gland, know that the parathyroid gland, okay, which produces the parathyroid hormone, which control,
So they're separate from each
it's attached at the back of the thyroid gland. So when you're going to remove it, usually they make a mistake and remove what? The PTH also. And remember, the PTH is what controls calcium secretion. And the moment that is also removed, then you're going to have what we call what? Calcium, low calcium in the blood. Okay? So you have the Chostek sign and Trozo sign because you're not making the what? The calcium anymore. You understand? So when they do that surgery, they accidentally nick the parathyroid hormone also, parathyroid gland, which produces the parathyroid hormone, PTH. When the PTH control, that hormone controls calcium secretion. Okay, so that's good. So when you're lacking calcium, muscle spasms, okay, twitching of your mouth. So those two signs right here on page 956. Take a look at that. Page 956. That's signs of what? Hypocalcemia. Know that it's always on your test. Chostek sign and what? Trozo sign. The Trozo sign has got to do with blood pressure. So for a patient who has low calcium, when they pump his blood pressure all the way above his systolic, their hands twitch like that, like it shows in the picture. And then for a person with low calcium, if they touch the cheeks, the what? The mouth will twist. See that? So that's signs of what? And you're gonna be asked that. Trozo sign, Chostek sign, and know which one is Trozo. I remember Chostek is what? CH, right? CH. So I remember cheek easily, right? Trozo is for the blood pressure when you go above the systolic. So remember, Chostek is the cheek, all right? Okay. So that's what I talked. So now we're going on to the parathyroids. For the parathyroid, we're talking about what? Calcium. So on page 958, they've done the table for you right there. Page 958 has the table. Comparison of signs and symptoms of hypothyroidism and hyperthyroidism. Okay? They've done all the table beautifully right there for you. Okay, so you can see a patient with goiter on page 961. Okay, so now let's go to disorders of the parathyroid glands. The first one is what? Hyperparathyroidism. This is the secretion of excess PTH. Okay, excess PTH, hyper. It can also be caused by a tumor. Okay, so you need to know what's going on with the patient that has too much calcium in their system. The first thing you can always remember is what? Renal calculi. What is renal calculi? Kidney stones. Okay? Calcium is calcium deposits. Remember that. So when they're going to go into the kidney and they form renal calculi. So it can lead to what? Renal failure. Okay? You're going to have twitching because remember, calcium is responsible for muscles, okay? So twitching and muscle spasms will happen, okay? It can even affect how your heart beats because you know your heart is a muscle, right? Okay. Even your breathing can be a problem, okay? So please no Trozo sign, no Chostek sign, okay? Know the muscle twitching is going to be affected. All right, so how do we diagnose that? We can do blood tests. We can do dental examination, EKGs, okay? Know that hyperparathyroidism is what? Secretion of the excess parathormone, which is PTH, okay? All right. So this table is also done for you on page 962. Comparison of signs and symptoms of hyperparathyroidism and hypoparathyroidism. Can you see that? Beautiful right there. So it affects the musculoskeletal system, the urinary system, the cardiovascular, neurologic, GI, integumentary, and the what? Temperature tolerance. It's all been done there for you. Okay? All right. So what are the signs and symptoms? Weakness, lethargy, anorexia. See cardiac dysrhythmias. So no potassium will cause also what? cardiac dysrhythmias. Okay, calcium will also cause cardiac dysrhythmias, renal calculi, kidney stones. Okay, all right. So we diagnose with the CT scan, MRI. We can also do the surgery, which is what? Going in to do the parathyroidectomy. So we're going to remove the PT, the gland that is behind the what? Thyroid. Beautiful. All right. So what are the medications we're going to give them? Lasix, because Lasix helps with what? Excretion of calcium. What other um, what other element does Lasix eliminate or excrete? Potassium. Okay. For the electrolyte right there. As usual, we're going to monitor vital signs, urine input or outtake, activity intolerance, of course. So when we do the surgery, airway obstruction again is number one. So all of these surgeries, when you see a question, know that airway is what? Number one. So give the person oxygen. Okay? And remember that when we do the surgery, the person will become hypocalcemia. So they got to be on what? Calcium supplement for the rest of their lives. And that's a question you can get. So be alert for what we call tetany when they have low calcium. So what is tetany? Tingling around your mouth and the fingers. Low calcium can cause that. Okay? All right. So protect the suture lines because we're going to go down here in front of the neck and go naked. So always make sure you protect it from stress because if it opens up, infection. Okay? So elevate the patient's head to reduce what swelling. Remember, I talked about that earlier. Always keep their head elevated. Okay? And inspect what? The dressing at the back of the neck for bleeding. Remember that? Okay. So the last one is what? Hypoparathyroidism. This is a deficiency of what? PTH. Okay. And so when this is happening, the same symptoms are going to happen. Low calcium, all the tetany we talked about, all the twitching and everything, difficulty breathing, cardiac dysrhythmias. Okay, the person's going to have cramps. All the things we talked about that calcium can do, what potassium can do, it's possible. So here we put the person on what? Oral calcium salts with what? Vitamin D. When you go to the nursing home, you see a lot of what? These patients on what? Calcium and vitamin D. What else does it help with? It helps with what? Preventing of what? Fractures. Okay? Remember that I told you earlier that a patient that is on a lot of what? Steroids is at risk for what? Osteoporosis, fractures. Okay? Don't forget that. And when it comes to calcium, don't forget the Chopstick sign and the Trozo sign. Okay? Don't forget about tetany, which is tingling around the mouth. Low calcium causes that. Okay? So give medications as usual. Okay? And let the person carry a medical ID bracelet because it's an emergency. Okay? All right. So that will be it, guys. Let me, I gotta stop sharing my screen. My online people, are you there?
Yes.
All right.
Yes.
Yes.
We got to, let me see.